All right. So again, somebody is logged in as a student. Can you update your name on your login so your name shows? I don't know who it is. Desiree, can you turn your camera on, please? Did y'all have a good weekend? Get some rest? Relax a little bit? No. All right. Thank you. I'm sorry. All right. So who is logged in as student? Can you update your name or do you need me to update your name? Can you hear me?
Desiree, you're logged in a student.
I don't think she can hear. Who is it?
I don't think she can either. That's who it is. She's logged in as a student.
Yep. Can you hear me?
Can you
Can
hear
you hear
me?
me? I
Yeah,
can hear you. Can you
yeah,
hear
you're
me?
logged in as student, Desiree.
I don't know how to change it.
That's fine. What is your last name?
Galvan Figueroa.
Okay, because you're logged in here twice. That's why I was confused.
Oh,
Okay.
what the heck? I had to have the tech guy help me, so
No, it's fine. I can update your name. I was just didn't know who you were. So let's see. I can do it.
I don't I don't know how to change it.
I got it.
Galvan Figueroa. I had to have the tech guy help me, so
Oh, I just spelled your name.
I'm hearing everybody talking. I'm hearing
Over and
everybody
over.
talking. It's like on repeat.
Okay, as long as you can hear us, I mean that's okay.
My name is spelt with a Z.
Oh, I'm sorry. Let me put my glasses on. Oh, okay. I spelled Desiree wrong. I apologize. I will fix that.
All I see is Patrick on the full screen.
All right. All right. Patrick, yeah, there you go. Priscilla, can you turn your camera on? Let's see. All right. Who do we have? So we're missing some still. So I have Mary, Teresa, Sabrina. No, Sabrina. Okay. Desiree, Priscilla, and then I saw Ruth. There's Ruth. Jasmine. Let's see. Mandy, Patrick, and then Dynasty. No, Dynasty. All right. So welcome to week 2. Um, Before we get started, I just want to make sure that you guys saw everybody. I'm sorry if there was any confusion. So on the PN134 exam blueprint and schedule live reviews, okay? So those are your live reviews for this week, all right? So you have one that starts tonight at 7 with Professor Kaminsky. There's another one tomorrow at 8 p.m. There's one Thursday at noon. There's one Thursday at 8:30. Then there's one Friday at 10 and 11. And then there is one on Sunday at 2:30. So one, two, three, four, five, six, seven different exam reviews going on this week. Okay, so those are there for you. Again, those are your exam reviews. So if you can pop into any of those, that would be awesome. It is going to only assist you in being prepared for exam one, which will be next Monday. So again, exam one is going to be next Monday, same time, 3 p.m. Eastern Standard Time. You will log into Zoom. Remember that you have to have two devices next week for your exam. If you are planning on proctoring on campus, you need to reach out to me personally. Okay, so I know that there were some that reached out to an on-ground instructor um, about the exams being proctored on campus, which is fine if you want to proctor on campus, but you have to send me an email and notify me as well. And then do remember that oh no, we don't. Never mind. I was going to say something different. But just remember that if you want to proctor on campus, you have to let me know within 72 hours of the exam. So Sabrina, do you know how to add your last name to your Zoom?
Yes. Do I have
Okay.
to add it every time?
Yeah, I don't know if
Okay.
some,
Because I think I added it last time. I can
yeah,
do it though, really quick.
you might have to go into your settings and update your settings. Otherwise, yeah, you'll probably have to do it every time.
Okay.
Amy, are you asking about the review recordings being recorded? Yes. Yes, absolutely.
Just
So as the can't even talk. As the reviews are completed, okay, they'll send me a link and I will post that in the announcements. So you absolutely will have links to the recordings. Absolutely. Good question.
You posting
Oh,
all of them or just some?
I'm sorry.
Are you gonna post all of them or just some?
No, I'll post all of them. If like if there's a review, then
Hmm.
all of their recordings will be posted. So, yep, no worries there. All right. So we're gonna go ahead and get started. We got some more people coming in. All right. Hi, Simone. Are you in my schedule? Are you in my class now?
Hi, this is
Sorry.
Patrick. I cannot hear
Got
you on my actual laptop,
got
so I'm
you.
using my
Okay.
sister's
I
one.
see it.
Yeah, I'm using my
Um,
sister's one.
yeah, just change your name unless you're gonna say logged in on both. Um,
Let me see if I can change my name here.
do you want me to?
Yeah, I want to change the name.
Okay, if you can't do it, just let me know and I will. And then somebody
Yeah,
just
you
logged in
can.
on, I'm sorry.
You can go ahead.
Okay.
Sorry.
Somebody just logged in, I guess on their phone. If you could update your name, and your login, that would be awesome. Okay, where'd they go? Okay. All right. So Patrick, Tuy.
Uysenge.
Say that for me. Say your last name for me. No, no, say it.
Tuys
Say it.
Tuisenge Patrick.
Chusinga. Okay.
Yeah,
Awesome.
that's nice.
All right. So again, like I said, all of the recordings or all of the sessions are posted there for you. With the Zoom links for you to attend, live session, if you can attend live sessions, that's better only because right? You can ask questions if you need to, but yes, absolutely, the recordings will be posted for you. So
Jennifer, can you hear me?
I can.
So I was having some technical difficulties. I was wondering what you were talking about the 7 o'clock.
Oh, so in your announcements, there's an announcement there with it says, what does it say? It says PNR 134 exam one blueprint and schedule of live reviews in week 2.
Okay.
So next Monday is your first exam. And so that all of those different times and dates, those are the exam live reviews. Okay,
Okay.
so those are your exam reviews, and there's 1 or 2 every day. I mean, there's 7 total. So lots of opportunities for you guys to attend the live reviews. And I understand if you can't try, but try to make one, and it does help if you can attend the live reviews, only because it can, also help you to ask questions if you need to. But everybody's schedule is different. That's why we try to offer as many as we can.
But they are recorded, yeah.
Absolutely.
Okay.
Absolutely. All right. Somebody is logged in on their phone. If you could update your name, please. It says Motorola Razr Plus 2024. Do you know how to change your name, or do you need me to change it for you? Yes, no, maybe. All right. So, I'm going to get started. If you need me to change your name, please let me know so I can update that for you. All right. So for today, so again, welcome to week 2. So I know I only heard about one person having any issues logging in and getting their assignments done this week. So we are going to um, go through the PowerPoint, ask any questions um, as we go through. So I'm going to share my screen so you can see the PowerPoint. Can you update your name on your Zoom?
No, I can't.
All right, no worries. I can do that for you. What is your name? You're on mute. You're on mute. Can you type it in the chat so I can update your name? Or unmute so you can tell me your name.
I have a question.
Yes, ma'am.
So, I was listening, but in our announcements, the syllabus thing that you sent us, is that where we are scheduling our live reviews?
No, the syllabus cover sheet is just there
Mm,
for you guys to have my contact information as well as the Zoom link.
okay.
Yep. In the announcement that says exam 1, blueprint, and live review dates, those are the exam review dates. Okay.
Okay, thank you.
You're welcome. Okay, I can't change your name because I don't know who you are. Can you unmute so you can tell me who you are? Whoever, anybody help me out? I don't want to mess up. I don't know who you are, so I can't change your name. Can you unmute so you can tell me who you are on the phone? You're wearing green scrubs. Can you unmute or type in the chat what your name is so I can update your name? Okay. All right. So I'm going to share my screen. Um, and we are going to go through the PowerPoint. Um, all right. Here we go. All right. So, HESI highlights for week 1 and 2. Um, So overview of the aging and the older adults. So there will be 1.4 billion adults age 60 plus by 2030. That's a huge, huge number, right? But then 2.1 billion by 2050 worldwide. So there is going to be a very large amount of the older adult population. The theories of aging, talked about last week, the psychosocial, the biologic, the developmental, health promotion, maintaining health through recommended screenings and immunizations, preventing accidents and infectious diseases, promoting safety measures, especially fall prevention, maintaining nutrition, hydration, and weight control, encouraging social interaction to avoid isolation, discouraging excess use of prescribed medication and over-the-counter drugs, and then elder abuse, the types of abuse and neglect, the risk factors for abuse, the physical, cognitive dependency, caregiver stress, healthcare professionals, we have a legal responsibility to report abuse, right? So as healthcare professionals, we are legally obligated, we are mandatory reporters. And your HESI, the information for your HESI, is in your HESI book. If you guys have not looked at that, you do have that HESI book, and it is chapter 8 is gerontological nursing. So for week 2, so this does cover, quite a few chapters throughout week 2. So we are going to, it's going to be in both of your books. So your basic geriatric nursing as well as your concepts for nursing book. So both of those. So some of the learning objectives for this week. Describe the concept of health promotion as it relates to older adults. Describe recommended health practices or health maintenance practices. Identify older adults who are at most risk, who are most at risk for experiencing health maintenance problems. Discuss the role of nutrition and fluid balance in health maintenance and disease prevention, and identify internal and external risk factors that affect older adults' safety. So we think of health promotion, and I know that you've had health promotion throughout your programs, right? And so health promotion, right, it is the process of enabling people to increase their control over and to improve their health. And a lot of times, right, when we think of health promotion, it is going to require a change in behavior, right, in order to adopt healthier living practices. And that's across the lifespan, right? That doesn't just apply to our older adults. Long-term success depends on the individual's ability to adapt to change. So whether it's eating a healthier diet, getting more exercise, um, in some cases it could be, teaching them new, ways to prepare their foods or even helping them to get access to foods. So how easy do you think it is for most older adults to adapt and change? How easy do you think it is? You think it's easy to change?
No,
Why not?
because you've been doing those things your entire life.
Habits, right?
Hmm.
So everybody has habits, right? We've the things that we've done our whole lives, right? And that's related to everything, right? It's not just diet and exercise. So how easy do you think it would be for, if we had an older adult that was a newly diagnosed diabetic, how easy do you think it would be for them to change their way? um, of eating. Um, what else? Even preparing foods. Um, Give me 1 second. I have a student that is trying to get on. Um, so what are some barriers? What do you think are some barriers to that? What are some barriers to change?
Some people, like far as like, for example, when you use the diabetic patient, it would be barriers if they had like financial issues, they're unable to change their way they're eating because they can't afford it.
Okay, so cost is a big one, right? Um, So that's always going to be a huge issue. Now we talked about last week, right? Not all of our older people are living in poverty, but we still do have quite a number that will be living in poverty and will have, may have difficulties affording making changes. But habits is a big one, right? If this is the way I've eaten my whole life, right? And now you're telling me that I can't eat that anymore, right? That could be a significant deterrent. Um, so we're always going to recommend, just like we would recommend for anybody, a well-balanced plant-based diet, right? Making sure that they're getting the recommended daily allowances of all of their nutrients. We're also going to recommend that they quit smoking. If they smoke, excuse me, even quitting now as an older adult can still have beneficial effects. Only drinking in moderation, making sure that they're getting their immunizations. What immunizations would we recommend for the older adults?
Flu.
Absolutely. The flu. What else?
What about shingles?
Very good. The shingles vaccine. They may still need, their pneumococcal or their pneumonia vaccine. They're still going to have to get their tetanus updated every 10 years. Um, so again, making sure that they get their vaccines, their health screenings. What health screenings, do we recommend for older adults?
Eye checkups.
Okay. What else? Yearly checkout, some or checkups, maybe every 6 months, depending on if they have, certain chronic diseases. What about other screenings? What do we recommend?
Cancer screenings.
Okay, so colonoscopies, your mammograms, pap smears, for guys, the testicular exams, right? Their PSA levels, right? These don't just stop because we're getting older. And, exercise, especially postmenopausal women, right? Those weight-bearing exercises are very beneficial, but maintaining activity, right? Whether it's walking, they don't have to go out and run, okay? Walking, swimming, even going in while, working in the garden, doing things like that can be beneficial. And then maintaining a healthy, positive attitude, right? We know that healthy, positive attitudes definitely helps the psychosocial aspect, right? And helps them from, helps to protect against things like depression. So proteins at every meal, reducing sodium, sugar, refined carbohydrates. This is where it's really important that we teach people how to read those nutrition labels. There's so much information on those nutrition labels that I don't know if anybody has ever looked at a nutrition label, but just sodium itself. There's sodium is in everything. I forget, and I don't remember which one it was, but one of the bottled waters, and I think it's one of the flavored waters, has a pretty good amount of sodium in it, right? So that's something, we think we're drinking, water, it's healthy. But being, paying attention to that as well. And I don't like water. I don't know about anybody else. I'm not a big water drinker. And so I drink flavored waters. I usually use Propel. Propel doesn't have a whole lot of calories in it, but it does taste, the little packets taste pretty good. Um, but we know we do have to teach them how to read these labels. Another thing that a lot of people don't often pay attention to is the serving size per container. Even like the serving size, because those calories right here on these little labels, right, that's usually going to tell us the calories per serving. It's not telling you how much is in there, right? So, even if you want to eat a bag of M&Ms, right, it's not just me. For me, it might just be one serving, okay? But technically speaking, right, there may be more than one serving. So teaching them how to read those labels. Most sodium and sugar are hidden, or in processed foods are hidden. So we do have to be really careful with that and really showing them how to read all those, as well as the percentage of the daily, gosh, the percentage of daily value that's in these foods, right? So look, whatever this is, it's got a pretty good amount of dietary fiber in there. Um, rest of it's kind of low, which is good. But then you look down here, hold on, we still got some people. Okay, someone is logged in as a student. What is your name so I can update it? What's your name, hun? I need to have your name updated so that I can make sure that you get attendance for today. Can you tell me what your name is?
Latosha Anderson.
Thank you. All right, gotcha. All right. And being aware sodium is more effective than restricting state table salt, right? Because, like I was saying, a lot of these, especially your processed foods, your canned foods, they use sodium as a preservative. So having, the understanding and knowing how to read these labels is going to be very beneficial. With exercise, like I said, those weight-bearing exercises, especially in our postmenopausal women, are very effective. It also helps to keep the joints flexible, maintain muscle, control glucose and weight, and promote a sense of well-being. It does not have to be aerobic, okay? So we're not saying you have to go and, run around the block a couple of times. Anything weight bearing, moving around, even something like, I guess, what is it called? Like Pilates, things like that, really help to, can keep those joints flexible and maintaining muscle mass. Maintaining muscle mass also will help with bone protection as well. And it also, helps to keep them active for as long as possible. It should be 30 minutes of continuous activity 3 to 5 times per week, so even if they go for a walk, um, gardening, swimming is a wonderful exercise. I don't know if anybody likes to swim. Sometimes in some of the colder weather, unless you have access to like an indoor pool, may not be so beneficial, right? But we want to keep them moving as much as possible. An older adult or older person can repair damage once smoking is discontinued. So it doesn't matter how long they smoked. In any time they quit, they're going to, it'll have positive effects on their bodies, not, may not reverse all of the negative effects that it has had, but they can repair some of the damage. There's lots of different things out there now to help people quit smoking. There's medications, there's patches. I've even seen other, commercials for other types of, quit smoking aids, that may also be beneficial. And believe it or not, alcoholism is a common problem in our older adults, people that, they were young ones too, right? And so they are bringing their habits from their younger years into their older age. And in some cases too, they may also start to drink a little bit more. And, a lot of people use alcohol as coping mechanisms. So that is one of the reasons why we may have an increase in that consumption. Um, your recommended health practices, your physical exams. So we talked about these, the annual physical exam, right? They should be seeing their healthcare provider annually. The cervical cancer screening, breast cancer. We didn't talk about bone density, but bone density is, also something important, especially again, postmenopausal women. Colon cancer screening, vision screening, dental, getting their blood work done. These are all extremely important. So your bone density screening, initial screening is usually done at around age 70. It is younger if there's risk factors, or if they have like bone fractures after the age of 50. For men, and then for women, initial screening is usually around age 65. Um, and then, of course, the colorectal screenings. So colonoscopies, usually every 10 years. Um, so sometimes a little bit more often, depending on what is, what is found on the previous exams and family history. Mammograms, your breast cancer screening, um, every other year, sometimes yearly, can be done as long as they're in good health. Um, at some point, the older adult may, decide to discontinue their mammograms, but we also will do mammograms in men, if they have the breast cancer gene or gynecomastia, because men too are at risk for developing breast cancer. Although the risk is much smaller, it is still always a possibility. All right, so here we go. What is the preferred screening exam for colorectal cancer? What is the preferred screening exam?
Colonoscopy.
Colonoscopy. What about for breast cancer?
Mammogram.
Okay. When should older women have their first bone density screening?
60.
70.
So for their bone density is 65 for women, 70 for men. And we know that helps us to determine their risk factors for fractures, see what else we may need to do. Um, Lipid panels. So we didn't talk about lipid panels, but how often do you think we should get our lipids tested?
Every 3 months.
Every 3 months? Um, it could depend on the individual adults. But for lipid levels, it could be every 6 months or it could be every year. It just depends on the individualized or the individual. Um, in some cases, if they don't have any heart disease issues, we can even wait and do it every 4 to 6 years. So it really depends, on their risk factors. Vaccines. Has anybody ever gone to the CDC and looked at the vaccine schedules?
No.
So if you go to the CDC website, this is just kind of an excerpt from the CDC website about the immunization schedules for older adults. It's good even for pediatric patients, adult patients, just to kind of see what the recommended vaccines are. So influenza is 1 dose every year, right? The Tdap is every 10 years. The pneumococcal conjugate is 1 dose at 65. Um, and then the pneumococcal polysaccharide is 1 dose after the first vaccination. We do have a single dose vaccine for pneumonia now. But I will tell you too, just for your reference, if you guys, plan to travel after you graduate, decide you want to take a vacation, go outside of the country, the CDC is a really good website. It will, you can go in there and see where you're traveling to and see if there's any recommendations for vaccines or even prophylactic treatments prior to going. So really good website to look at. So with our coops, sorry, we have a nice little case study. So Mrs. Scott is 71. She is here for her annual exam. The LPN is reviewing Miss Scott's record and sees that she has had the following immunizations. Shows shingles was in 2020, her PCV, which is the pneumococcal conjugate, in 2024, the other pneumonia in 2025. She had a Tdap in 2015, and she had her flu in November of 2025. Which vaccine or vaccines will the LPN administer today to bring Mrs. Scott's immunizations up to date? So what does she need?
It looks like the tetanus. That's every 10 years.
Yep, absolutely. So she's good for that. She's good for her flu, right? But she definitely needs to get that tetanus booster. Good job. Dental exams and preventative oral care. So they should see the dentist every year. Even if they have dentures, they need to make sure that they are still seeing the dentist. If the if the dentures don't fit correctly, right, that's going to prevent them from eating appropriately. Um, People can, sometimes if people lose weight or they have some sort of gum atrophy that's going to cause their dentures to be too big, they're not going to fit appropriately, which is going to interfere with nutrition. So we need to make sure that they fit appropriately. Um, Dentures should be brushed or soaked to keep them clean, right? And then dry mouth is also common in our older adults, and that's not just related to dentures. As we get older, okay, as things start to atrophy and things start to decline, we may not produce as much saliva. So there, it is something to that we can, whether it's increasing our daily fluid intake, but there's also like some commercial products that can help, like some mouthwashes. I know that uh, in working in long-term care, we use some mouthwashes that help to keep the mouth moist. There's also artificial saliva that is available as well. Again, it's just to try to keep the mouth moist. Not, whether the cause is medications or another disease process that's going on that causes that dry mouth. If they have their teeth, dry mouth can also lead to dental caries and other issues within the mouth. So we need to make sure that the mouth is kept moist and that they're getting, periodic checks. Um, Most adults' health practices are formed early in life. And we know that, right? And you can look back, did you go to the doctor often as a kid? Did you go to the dentist, as, every 6 months or every year? A lot of these practices were established when we were younger. And knowledge of those recommended health practices is essential to make those good choices. And again, this could be something that we may need to overcome, right? Some of those behaviors that maybe they learned different, growing up, maybe going to the doctor and going to the dentist, getting their eyes checked, things like that weren't as important as other things. And so we need to make sure that they still follow through with those things. Patients can choose or decline care. We can't force them to go to the doctor. We can't force them to go to the dentist and do all of these things, right? This is where education comes into play, making sure that we're making sure that they know that these are recommended in this age group. Adherence, right? That means following through with a treatment plan or sticking to the plan. And why would a patient be non-adherent, right? So what are you think in addition to just basic habitual things, what are some other reasons why you think an older adult would not stick to a treatment plan?
Insurance.
They
Insurance.
could,
Okay. Sorry. I heard insurance, something else.
could it be like a patient can have like denial, like they're
Oh,
not.
okay. They can be in denial. Hey, this isn't really happening to me. I don't need to do that. That's a good one. That's a good point. What else?
Could be that they don't have like help. So like if it's something that they're doing at home, they may not have help to be able to complete the task if it's somewhere like a wound that they can't reach.
Okay, they may not have help. They may not have transportation. What if they can't drive anymore? Right? Or,
Could it
somebody
be
said, I'm sorry,
could it be like something religious?
could be religious, it could be cultural. Absolutely. Right? So there's lots of different reasons why people are non-adherent with their treatment plans. And so when we are doing our assessments, right, we try to identify as many barriers as possible and try to figure out how we can overcome those barriers. Um, and so, you guys brought up some really good points, right? The lack of health, the lack of insurance, or just even a lack of knowledge as well. Like, why are these important for me to do? Like, what is the importance of this? Right? I'm getting older. These things are supposed to happen, right? I'm supposed to start declining. But not all decline irreversible, right? There are things that we can change to help improve that older adult. So being able to recognize those barriers, right, and trying to change. How long does it take for someone to develop a new habit? Let's say that you decide, everybody does this, everybody comes up with their New Year's resolutions, right? Right around New Year's. And a lot of those New Year's resolutions fail, right? Whether it's um, I'm gonna start working out, I'm gonna start eating better, I'm gonna start doing this or that. How long does it take to start to make a habit stick? Does anybody know?
21 days, I believe.
Right, 21 days. So you have to do something every day for 21 days. And after that 21 days, it will become a habit for you. And that is something that you will stick with. So it's not something that's going to happen overnight, right? It takes time, it takes dedication in order for that to occur. So when we look at impact of changes related to accessibility, mobility is a big thing, right? So maintaining health is affected by sensory changes, right? There's decreased physical mobility, decreased stamina, lack of transportation, limited finances. This is, when we think of you know, if the risk for the risk for chronic diseases increases as we get older. And many of our older adults have more than one chronic disease. And so that can make the exercise, and moving and getting around a lot more difficult. Lack of transportation, depending on, their age and their physical abilities, their psychological abilities, right? Transportation means that it's more difficult for them to get to their doctor's appointments, to get to the grocery store. What else do we need to do? Even socialization with friends, going out to lunch, right? That can be a huge burden, and finances. Um, the baby boomer generation really, and even more so in the older part of the baby boomer generation, they were really the last generation that had pensions, right? Where you get that steady check right after you retire. A lot of the younger baby boomers and down, right? We have things like 401k and 403 Bravos and things that if you didn't put enough money into those and you're getting ready to retire, that's going to limit what your income is. Now, there people qualify for Social Security, Medicare, those types of things, but Social Security, it's a decent amount of money, but you're not going to get rich, right? Making on Social Security. And so the older adults also have to be able to budget their money, so that, they have money to pay their bills still, right? Buy foods, get their medications, and do all of those things. So there's, sometimes there's barriers when we're looking at these older adults and what they can and cannot do. Um, Home health is something that is going to, I mean, we already see that there's a significant increase in home health. Um, and it's only going to increase, as as the baby boomer generation continue to age, and we come closer to closer to those millions of people that will be, aged 65 and older. And home health doesn't always have to be a professional, right? If they're ill or they're recovering from surgery, absolutely, they may be entitled to a CNA, an RN, LPN, the OT to PT, sometimes respiratory therapy, but help can be received from family and friends as well, right? A lot of our older adults, we have a spouse that is caring for, an ill spouse. We have children that are, caring for their older or their aging parents, right? So there's a variety of different opportunities, and there's even like, church, there may be assistance through their church or their religious organization as well. Um, What's the difference between hospice and home health? What is hospice care?
Hospice is like end of life comfort care,
Yeah.
palliative care.
So hospice is our end of life care, right? So, um, once we get to that point in a disease, sorry, in a disease process where, um, those life-saving treatments or even just the treatment for some of our chronic diseases is no longer effective, and they are continuing to decline, right? Then hospice care is an option. And the premise behind hospice care, right, is death with dignity. So we're going to help the patient as well as the family through that process. Chapter six. So in chapter six in your oh my gosh, I can't even say the word, your basic geriatric nursing, we're gonna look a little bit more into maintaining fluid, balancing and meeting nutritional needs. Oops, I jumped ahead. But what are some things that influence our caloric needs? So how do we know how much to eat or how much we should be eating? What are some of those influences out there? What
Uh,
influences how much we
Meal,
should?
meal
I'm sorry.
planning,
One more time. I'm sorry.
um, meal planning.
Okay, meal planning. What else?
but not the pyramid.
Okay, using the pyramid. But does an older adult need to eat as much as, say, a 16-year-old?
No.
No. So when we look at some of the things that affect our caloric needs, our age, okay, our gender, activity level, our health, our emotions, climate also plays a huge part in our caloric intake. And so the lowest recommended daily intake to meet nutritional needs is 1,200 calories per day. Does anybody count calories? Know exactly, can tell you, okay, how many calories that you have per day? Some people are really good at counting calories, right? They know exactly what they're putting into their body and what their nutritional needs is. Go ahead, Priscilla.
I use an app.
Okay, but that's
I use the
fine,
app.
right? That's absolutely fine, right? Because sometimes those apps can be a lot more or a lot easier, right, than trying to figure it out in your head. And older adults, we can teach them how to use apps too, right? So they're a lot more tech savvy because, they've had to learn how to adapt to to technology and use technology. So it is something that we can teach them. But whoever said it, myplate.gov, awesome resource, right? I don't know if anybody has ever looked at it, but myplate.org is an excellent resource for our older adults. Well, for anybody really. Um, the current dietary guidelines for Americans, right? My plate. That's going, it can help them with meal planning, right? Even like, how much of this should I have? How much of that should I have? So that is something, they can go on, they can make them, plan a meal. They can also look for some, maybe if they need to, some lower cost options, right? Um, but other things that, we look at it, how well do we move around? Obviously, an older adult that is still very active, that is swimming, that is maybe, golfing or, out walking every day, right? Their caloric intake needs maybe a little bit higher than someone who has a more sedentary lifestyle, right? Because the less I move around, the less calories that I need. But at that same time, if I have a chronic condition or I'm sick, if I have pneumonia, the flu, any of those things, right? Then my metabolic needs increase, right? Because my body needs more energy to fight off those infections. So we have to kind of take all of those things into consideration. So we know about the imbalanced nutrition, right? Too much or too little. And so, and I will say not always, with the too much, this not always is related to eating too much too. There could be other um, disease processes and other issues, endocrine issues that go in according with, that being overweight. So we have to, when we just like doing an assessment, providers are going to do labs and other things to assess their patients to see if there's disease factors that play into that. Too little, of course, too little is just as bad as not enough, right? Because if you're not eating enough to maintain um, your nutritional requirements, how do you feel when you don't eat? Tell me how you feel when you don't eat,
Weak.
Tired, sluggish.
Easy.
right? Tired, sluggish, run down, like, oh, I don't have energy. I don't even want to get out of bed. Okay. So body needs fuel, right? Doesn't matter how old we are. Of course, our intake needs may be less, but we still need to have fuel in order for our metabolic processes to function. What are some problems with being overweight? What does overweight do?
Causes stress on your body, your joints.
Okay. Can cause stress on your body, your joints. What else?
Your heart.
Your heart, right? Your vascular system. Obesity is also linked to certain cancers. Okay.
Mhm.
So maintaining healthy body weights is super important, right? It also affects our mobility, the ability to
Mhm.
get around, and do things that we would, normally be able to do.
And it's like you're more prone to bed sores because once you can't move and do things and you're
Can't,
overweight.
you
Yeah.
can't move around, right? Um, High blood pressure, stroke, or increases the risk for stroke or heart attack as well. Very good. The skin integrity issues, and not just bed sores. Um, it's like yeast and other types of irritation
Oil.
yep, in the skin folds that can potentially cause issues with skin as well. Diabetes increases your risk for type 2 diabetes too, as well. So, um, what about some, what about, we talked a little bit, but what are some of the problems with being underweight? How does that affect your health?
You don't have enough vitamins in your body.
Right? And you're not getting the protein, you're not getting the carbs that you need for energy, right? You're not getting the
Muscles are
protein for
weak.
muscle building.
I would say muscle building.
Yep. 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 So also look too, you're not going to get enough white blood cells, enough red blood cells. Um, and then of course your bone strength, right? If we're not getting our vitamins and minerals like we need to.
Which could lead to anemia also.
Mm-hmm.
Or like
And
immune weakness because you're not getting all the minerals that you need.
absolutely. So you're suppressing your immune system, which is going to make you more susceptible to illness, right? And then just think about anemia, right? You're tired, you're sluggish, you're not perfusing like you should. Good job. Daily nutrition and fluid. So again, 1,200 calories, that's the minimum that we should eat. And then unless they're fluid restriction, it's still 2 to 3,000 mLs of fluid per day. So how many drink 2 to 3,000 mLs per day, or 2 to 3 IV bags per day? It's a lot of fluid. It's a lot of fluid, right? Anybody get that much? I try. I try. I try to drink as much as I can. Um, but why are older adults at a greater risk of dehydration than younger adults?
A lot of times they don't want to drink because they don't want to have to use the bathroom so often.
And
Right.
a lot of times they also forget.
Okay, and as we get older, we start thinking of dementia and things like that. Absolutely. Um, yeah, forget to drink. But with older adults, right? So, babies are like, I forget what the actual percentage is, but they're pretty much a lot of water, right? Then as we get into our adulthood, we kind of level out. But then when we get to about the older age, 60% of the average adult body is water. Okay. And then it kind of decreases a little bit when we get older. But yes, absolutely still need water. And like you were saying, what are some of the reasons why we don't drink? Well, for one, you're right. Mobility issues may be a big part of that, right? If I drink this, that means I'm going to have to get up and use the bathroom. And that means it's going to, it's harder for me to get up. It's harder for me to move around. And so I'm just not going to drink because then I won't have to go use the bathroom, right? And fatty tissue holds less fluid as well. And so we have a decrease in muscle mass. And so again, older adults still need to drink. It is super important. Um, into it. So look at fluid volume deficit. So nice little nursing diagnosis here. So some of the symptoms that if we're not getting enough fluids, what's going to happen? Um, orthostatic hypotension, increased heart rate, right? Because if I don't have enough fluid, if I don't have enough blood in or, plasma moving around, it's going to make my heart work harder, right? Because I need to get that oxygen. If I don't have enough, if my heart's going to keep trying to push it out, right, to get the oxygen to the tissues. Restlessness, anxiety, weight loss, confusion, extreme thirst. What else? Decreased cardiac output, in severe, fluid loss, weak or absent pulses.
Um,
Another issue with the elderly too is they may have some issues with that thirst, the sensing that they're thirsty, which also decreases their wanting to drink. Fluid volume excess, they're going to have the fast heart rate, they're going to have the shortness of breath, they may have some crackles in their lungs, right? That's, just from fluid buildup, hypertension, unless they're in heart failure, a weight gain, edema, difficulty breathing when they're laying down, and they're at a huge risk for both, with the older adults. So here we go. So which condition in older adults can cause fluid volume deficit? What are some things? So three out of four of these cause fluid volume overload. So which one can cause a fluid volume deficit? You already mentioned it.
Altered,
Yep, the
altered
altered
cognition.
cognition, right? Good job. All right. So before we go into barriers to nutrition, let's go ahead and take a quick break or take a break. So be back at 4:15.
Are you speaking to us? Because we cannot hear you.
Thank you so much. Yes, I was talking to y'all. Um, so sorry. So what are some physiological barriers to nutrition for older adults? I was wondering why nobody was answering me, but I was like, I'm gonna keep going.
It's I think it's expensive for the organic food
Okay.
or the food
Okay.
with high proteins. They're expensive and hard to find,
Okay. All
and they
right. So
cannot
some,
drive sometimes to go to get what they want.
okay. What else
Yeah,
would be a physiological barrier to nutrition? Think of like,
physiological
I'm sorry,
things, different
like
culture.
Like a
within their body. Like when I say,
decline sensory of taste and smell.
okay, so decline sensory and taste and smell. Okay, that would be a good one. Think of some of your disease processes, right? So,
Not having like an appetite, like a urge to eat.
okay, so a decrease in appetite, definitely. Um, what about if I have arthritis or like rheumatoid arthritis and my hands don't work,
So you can't
right?
feed yourself. You'd have to have someone like be a feed or assist.
Right. So yeah, they may not be able to hold their utensils appropriately in order to feed themselves, or even when they're trying to prepare foods, right? It may be more difficult. Um, People that have like COPD, right? If they have COPD and it's hard for them to eat and breathe, right? While they're obviously they may choose breathing over eating. And so these are all things that we need to, think about when we're working with these older adults. What are some
One of the
psychosocial?
saddest
Go
things
ahead.
I've ever seen is somebody trying to eat that has Parkinson's really bad.
Okay, yep, that is a really good one too, Parkinson's. Because when they have those tremors, right, they're not able to get the food, right? It's hard for them to get the food into their mouth. That's a good one. Um, what about psychosocial factors? And we talked about this a little bit earlier, but what are some psychosocial factors that affect nutrition in our older adults?
Loss of like independence or mobility.
Okay, loss of independence and mobility, absolutely, right? If I can't, if I'm not able to drive and I can't get to the grocery store, or if um, I don't have the funds, right? Or even sometimes, having a lack of motivation to cook, right? Depression is a big part of that, as we get older, right? We start to lose friends, we may start to lose, family. Um, and so, if it's just me, right, I may be less inclined to cook. So, but and of course there's the monetary aspect, like Patrick was saying, right? It may be a little bit, maybe I don't have a whole lot of funds available to go shopping, or, be able to pick out the most appropriate foods. Other things that we didn't talk about, poor dentition. So remember I said, even if they have dentures, they still need to go to the dentist to make sure that, those dentures are fitting properly. Because if your dentures aren't fitting properly, you're not going to be able to chew your food. It also can cause more pain. So the limited dexterity, we talked about it. It could also be pain, right? If we're in pain, we're less likely to do a lot of things. And so that if they know, getting up and trying to, cook dinner is going to cause them pain, then most likely they're probably not going to get up and cook. And then the psychosocial, the depression, loneliness, loss of a partner or family member, lack of transportation, lack of money. All right, so from the HESI, so which factor promotes adequate nutritional intake in our older adults? So, following cultural eating habits, living alone, having scheduled transportation, or maintaining vigorous exercise. Which of those is going to promote adequate nutritional intake in our older adults?
Maintaining vigorous exercise.
Okay.
I'm gonna say following cultural eating habits.
All right. So having scheduled transportation. Okay. So think about it. If I don't have transportation, how am I going to follow my cultural eating habits? Or maintaining vigorous exercise isn't necessarily going to promote adequate nutritional intake, right? I have to be able to get to where I need to go. And I will tell you from personal experience and dealing with older adults, even sometimes we having those cultural eating patterns, we do know that sometimes it does help them to eat a little bit more, but it doesn't always provide for, the adequate nutrition, depending on their picking and choosing what foods that they are going to want to eat. Um, and so here we go. So fluid regulation is one of our natural processes. Okay, so some types of fluid losses are abnormal, all right, and they need to be monitored. So what is the normal way that we lose fluid in our body? What's the normal ways that we lose fluid?
Urination and sweating.
Urination and sweating, absolutely.
Vomiting.
I'm sorry?
Vomiting could be one
Okay,
too.
vomiting, absolutely. What are some other ways that we lose fluid? Normal.
Diarrhea.
Okay. Diarrhea. Not normal, but yes, diarrhea. Respirations, right? When we talk and we breathe, we do lose some fluids there. Your abnormal, that would be like your diarrhea, your vomiting, right? Those would be abnormal. We also lose fluids in our stool, not a tremendous amount on the normal side. Okay. But of course, that's going to be increased, right? If we have diarrhea. Wound drainage is another one that where we would lose fluids, right? So think of somebody that has maybe even a surgical wound or even like a really bad pressure area, right? And they're losing they have a lot of drainage in that wound. And gastric suctioning. So if, for whatever reason, if we have to, if somebody needs to have their stomach, if there's like a GI issue and we're decompressing the stomach with a G tube, that could cause, and obviously, abnormal fluid loss. Um, let's see. So food for health, your green leafy vegetables, spinach, kale, those are, are good iron sources. Milk, is a good calcium source. Your salmon, some of your vegetables, nuts help with vitamin B intake. All right. So what does when we look at these lab results or we look at these lab tests, what does hemoglobin tell us? Why do we look at hemoglobin?
The amount of red blood cells.
Okay, the red
Blood.
amount of red blood cells, awesome, right? To bring the oxygen right to our tissues. What is BUN?
The bun. Blood urea nitrogen, which it measures the amount of nitrogen from urea waste in your blood, acting as like a
Okay,
key indicator of kidney function.
kidney function, good job. What about creatinine? Which organ is that
It
measuring?
the kidney function as well
Very
measures
good.
the level of waste from kidney.
Yep. What is albumin?
Question.
A protein produced by the liver.
Okay, so albumin is protein. So that's telling us, right, how much protein. Why is protein important in our blood? What does protein help to do?
Like a
Strengthen
new
the muscles.
Okay, it helps with the muscles, but
Source of the
why?
energy.
Energy, okay.
Goes to the kidneys, right?
With what
it,
with the kidneys?
it helps it helps to assess like liver and kidney function for like the nutritional status. So if like there's a malnutrition or like disease or kidney disease, it's able to determine that by the levels.
Okay. And also with albumin too, it helps to maintain our plasma oncotic pressure, right? So it helps to keep the blood in our blood vessels, right? So that it could help to prevent edema and fluid leaking out. Yes, Patrick, you have your hand up.
I have a question.
Yes,
I wanna know the difference between creatine and the creatinine.
do you mean creatine and creatinine?
Yes.
Okay, so okay, because I was like creatinine and creatinine. Okay, so creatine is found in muscle cells. Creatinine is a product that's formed from the breakdown of creatine. Okay, so creatine is in the muscles, and if it is broken down, it is broken down into creatinine. All right, so it just shows that if we're breaking down that waste product, and then everything is secreted by the kidneys, so it just helps us to know if the kidneys are functioning appropriately. If that makes sense.
Thank you.
And then calcium, right? We know we need calcium for a variety of different things, but we mostly think of calcium and bone strength, right? And so especially in postmenopausal women, right, we need to have maintain our calcium levels. What is needed for calcium absorption? What
Vitamin
other
K.
vitamin is needed?
S- Strengthen the bones.
Right. Yeah, calcium is there to strengthen our bones. But what do we need for calcium absorption? What helps us? Vitamin D, right? Vitamin D and calcium generally go hand in hand. We need vitamin D and calcium together for absorption. And then glucose. Okay, so fasting glucose, and this one says 74 to 106, but I will tell you, depending on what lab you're looking at, because different labs are going to have different values. Right, we want to maintain those glucose levels just for normal daily functioning, right? And then if start to elevate, we want to monitor that hemoglobin A1C, right? Assess the risk for type 2 diabetes. And then we have chapter 9. So meeting the safety needs of the older adult. So types and extents of safety problems. So unintentional injury deaths among older adults in 2022 was 227,039. Significant amount. Largest number of deaths in 2022 were from accidental falls. Most common safety problems: falls, choking, poisonings, burns, automobile accidents, and extreme temperatures. So falling once doubles a person's chances of falling again. Okay, so many independent older adults are reluctant to report a fall because the implication that they are frail and dependent. But in addition to causing bodily harm, falls do have a huge psychological toll on the older adults. They lose confidence, they decrease mobility, especially if there is a fall with a fracture. And unfortunately, I've seen this a lot over my time in long-term care. You have a nice, great, active older adult who's out walking, maybe, maybe even still jogging and, playing tennis and swimming and things, and they have a fall and they break a hip. It absolutely breaks their confidence. Why? Because of their fear. Fear from falling again, fear from, breaking something else. I've also seen it lead to severe depression, where this once older active adult is now completely reliant on another person for caregiving when that depression kicks in. So we want to try to decrease the falls in this population. So there are things obviously that are going to increase our risk for falls as we get older, right? Vision decreases, even our hearing decreases, which also increases our risk for injury. Decreased sensitivity to smell and taste, increase the risk of accidental food or chemical poisonings. Cognitive changes reduce the ability to recognize and process information. Um, Urge and urinary incontinence, bare feet or inappropriate shoes. All right, this is another thing that could, just some things that could increase their risk for falls. Other things, decreased flexibility, mobility, muscle strength, the slowed reaction time, gait changes, altered sense of balance, postural changes. All of these are going to affect safety, right? Just think about it. Something slight like, let's say, slowed reaction time. This could even be while they're driving, right? Whereas, let's say they're driving down the road and a dog runs out in front of the car, right? They may not hit the brake, right, as fast as they would have when they were younger. Difficulty lifting their feet, shuffling gait. Somebody mentioned Parkinson's earlier, right? Parkinson's have this, patients with Parkinson's have this classic shuffling gait. All right. So they shuffle their feet. They don't pick up their feet much when they're walking, right? And if there's throw rugs and cords and other things on the floor, right, that's obviously going to increase their risk for falls. Cognitive and sensory changes. So, significant cognitive or perceptual problems increase the risk for self-neglect, illness, injury. I know a lot of times we think of dementia when this occurs, right? Especially cognitively. Um, our dementia patients may forget to feed themselves, right? They may not shower, they may not care for themselves, and it's not on purpose, right? This isn't something that they are doing willingly, but those cognitive changes, they don't recognize the signals in their, that are saying, hey, I'm hungry, or you need to use the restroom, or whatever it is. You need to drink some water. They don't recognize those signals. And then sometimes those signals are depressed in that older adults. So this picture represents a visual disorder. Does anybody know what this visual disorder is? Really blurry,
And
right?
glaucoma.
Okay. So what health risks do you think that, presents to someone if that's what their vision looks like?
They're not able to see like what they're grabbing or like medication. They could accidentally take the wrong medication.
They can take the wrong medication, they can trip, they can fall, they can walk out in front of a car, right? There's so many things. Could you imagine if somebody with this vision was getting in a car and trying to drive? That's safe, that's huge, right? So yes. And then this is actually cataracts. Okay. So this is severe cataracts. And I will tell you, someone, I have had cataracts before. I had early onset cataracts, then I had cataract surgery at a young age. But um, I will tell you that, I mean, I was visually corrected. I was not this bad. I was still able to see with my glasses, but even, things were still really blurry, very difficult sometimes to distinguish colors. They just looked more dull, okay? But if they're seeing like this is horrible, right? And there are people that live like this, and a lot of times they don't know that this can be helped, this can be fixed, right? I mean, I'm going to tell you, I'm here to tell you it's not the most fun surgery in the whole wide world, right? Because they're messing with your eyes and you have to be wide awake when they do it. Um, but afterwards, I mean, it's amazing. But yes, medication errors, nutritional deficits, accidents, injuries, overdoses, all can be the result of something like that. Hearing impairment, perception of danger, communication. It is a barrier for even when we are providing our patient education. They may not be able to hear us. They may misunderstand what we are saying. Um, we talk to people that are hearing disabled or hearing impaired. We don't yell at them. Okay. We use a lower tone of voice, not a high pitched tone, because they will have more chance. They can hear lower tones better. Um, we also want to, face them when we're speaking, and not over enunciate our words. A lot of people have adjusted, they can read lips, as they start to lose their hearing. So making sure that they can see your face. Um, if they have hearing aids, which I think it's great that some insurance companies are now even helping to pay for hearing aids, because for the most part, hearing aids were out of pocket expense and very expensive. And that's one of the reasons why, if you're caring for somebody that does have hearing aids, that you are caring for their hearing aids, or if they have hearing aids, that we're caring for the hearing aids appropriately. Um, I know in long-term care, hearing aids and dentures were among our biggest difficulties, because they would take them out, both of them, hearing aids and dentures, put them on their tray or wrap them in a tissue, and then they inadvertently get put in the trash. So keeping track of them, making sure that they remain in working order. They still need to get them checked every once in a while. Depending, some still have batteries. And I've seen some now that are rechargeable that need to be put in a charger at the end of the day. But they still need to be cleaned, because earwax can build up inside the hearing aid and prevent them from hearing appropriately. Talked about Parkinson's disease. Parkinson's disease is, one of those ones, and you may see, but this is the traditional, some of the things that you'll see with your Parkinson's disease patients. The shuffling gait, like I said, the stooped posture, they'll have like a flat affect or a masked face. They don't show emotion. Um, Reduced arm swing. They'll also have tremors. And like someone pointed out earlier, it's very difficult them, especially when the tremors are severe, for them to feed themselves. So, nutrition is something that we do have to worry about with them. Um, there's other ones. I mean, Parkinson's or strokes, there's MS that could also make it difficult for them to maintain nutrition. But it also can lead to gait imbalances, which are all going to increase their risk for falls. Arthritis as well. Arthritis reduces mobility and flexibility as well. Medications. This is probably one of the biggest concerns with our older adult population. is medication use. Any medication that alters sensation or perception, slows reaction time, or causes orthostatic hypotension is potentially dangerous for the older adults. And there's a lot of those medications out there, right? Just think of your blood pressure medications, right? All of your blood pressure medications increase the risk for orthostatic hypotension, which is going to increase their risk for falls. So think like a nurse. So the nurse is interviewing a family member of the hospitalized 90-year-old client to assess for common problems associated with an increased risk for falling. Which questions should the nurse ask? All right. So if we have a person that is at an increased risk for falling, what questions should we ask?
Has your mother
Have your
fallen in the
mother.
past year?
Okay. Has your mother fallen in the past year? What else should we ask?
When
When
was the
was
last
last
time?
time you got pain?
Okay, took a pain pill. Okay, what else?
Um, does your mother have difficulty falling asleep?
All right. So, has your mother fallen in the past year? Past fall, high risk. When was the last time your mother took a pain pill? Pain meds, opioids, right? We already know those are a high risk. Does your mom have any problems with urination? Incontinence also increase the risks, right? Especially think of things like urgent continence, right? They don't always get that, oh, I'm gonna have to go to the bathroom. Sometimes it's like, oh my gosh, I need to go use the bathroom right now and then. And what ends up happening? I start to rush, right? And that increases my risk for falls. And yes, does your mother have difficulty falling asleep? Okay. Medications, being up in the dark also increases the risk, right? Especially, if it's dark and they don't have any like night lights or other things to help them see, right? It's going to increase their risk for falls. I mean, we've all done it, right? You get up in the middle of the night because you have to use the restroom. I I'll either bump my foot on my bed or I'll hit the door jamb on my way into the bathroom because I didn't I didn't give myself enough space because it's the middle of the night. Other things that increase the risk for falls, so environmental hazards, environmental hazards. Okay, so some of the environmental hazards, think about the clutter, the throw rugs, um, what do you call those? Electrical cords, furniture sometimes can be a risk. Or if they're going up and down stairs. So making sure that there's banisters and that there's grab bars in the bathrooms, so that there is something there to hold on to. Um, Making sure that they have smoke detectors, the what are those things? Carbon monoxide detectors. Also making sure that that hot water heater isn't set too high. Everybody, I remember a few years ago we got our hot water heater and I swear I swear it felt like it was set to 200 and I didn't even realize it until like I turned on the hot water and I was getting ready to do dishes and I was like, oh my gosh, that is way too hot. So I had to go and turn it back down. Um, Internet safety. So let's talk about internet safety in the older adults. What are some potential issues for the internet in our older adults?
The scams that they get, like emails thinking that they have a bill due and they pay and it's not a bill that's due.
Right? Isn't it crazy? And you know that they target those older adults, and it's sad that they do that. And a lot of it too is not knowing, right? Think of our older adults. I mean, honestly, it's not like our younger generations that we weren't born with smartphones in our hands, right? We have this availability of technology. And so while they may understand a lot of it, right? They don't always understand all of it, and they are going to be at an increased risk. And so again, education is the best. Making sure that their passwords are good, that they're not, posting, that they're, not giving out information where they shouldn't be giving out information. Um, vehicle vehicle accidents. Um, and so, I will tell you, as just like in working with older adults, it's hard for some of them to give up their driver's license. Some of them recognize, like, hey, I can't drive anymore, because of this, this, and that. Others, they're going to be a little bit more reluctant to give up their license. There are safe driving courses for older adults that are offered. I want to say ARP does offer one too. But there are some, there are some safe driving courses that can, be helpful. Most of our house fires are cooking related. So again, the smoke detectors, even being cautious with cigarettes or open flames. If they're using oxygen, that they shouldn't be smoking, or anybody shouldn't be smoking with around the oxygen. And of course, checking extension cords for fraying, loose plugs, and always have an escape plan. That's always a big thing, is how you're going to get out of your house if something happens. And that's not just for older adults, that's for all of us. Talked about this. Uh, let's see. Some of the warning signs when people should stop driving if they don't feel comfortable driving or they're overly nervous. If they can't stay in their lane. Um, if you start to see they have more dents or scrapes on their car. Other people are honking at them more often. Confusing the brakes and the gas pedal is a big one. And if people start to do that, that's probably a really good sign that they don't need to be driving anymore. Any medical conditions or medications that affect their ability to maneuver, if they're easily distracted, if they're getting lost, if they start getting more warnings or traffic tickets, could potentially be time to, give up the driving. Um, Thermoregulation in the older adult, the ability to maintain body temperature in a safe range is controlled by the hypothalamus. And so things that internal factors, your muscle activity, circulation, your amount of subcutaneous fat, metabolic rate, amount and type of food and fluids, ingested medications, disease processes, they all affect our ability to regulate our temperature. External factors, humidity, environmental temperature, air movement, type and amount of clothing that we wear. So hypothermia is a poor temperature that is less than 95 degrees, or like I said, less. Normal changes that occur with aging affect the ability to regulate temperature. Changes in the skin reduce the ability to perceive dangerously hot or cold environments. And then, of course, the decreased muscle tissue, the muscle, decreased muscle activity, circulation, reduced fat, decreased metabolic rate, all affect the amount of heat produced and retained by the body. And so if you ever notice, anybody that's done a clinical in a nursing home or in a long-term care facility, those older adults are always cold, right? Maybe 100 degrees outside, but you go in the room and they still have the heat on, right? It's just their body has that, the inability to thermoregulate. Also, too, why a lot of our older adults either move to the south or they'll spend their summers up north and then their winters in the south, right, to avoid those cold weather. Let's see. Interventions to prevent hypothermia, keep the room temperature 70 to 75 degrees. Wear layers. maintain nutrition and hydration, stay active in the cold months, right? Don't just sit around inside. You still need to be active, avoid alcohol. And anybody that is hypothermic, it does require immediate intervention. They're depending on the severity of their hypothermia, their pulses may not be palpable. And so we want to get them in a warmer environment, wrap them in warm blankets, but we don't want to use like heating pads and things like that because we could potentially burn them. Offer warm beverages, non-alcoholic. Um, so Ed has been outside blowing snow off the sidewalk all morning. When you show up for his home health visit, his speech is slurred, he is confused, and he has cold bluish skin. Which would we anticipate? So if I'm really cold, what's going to happen to my pulse?
It's gonna
Goes
be
down.
low.
Okay. So which one of these would be a true?
Second one.
Very good. Yep. So my heart rate and my body temperature are going to decrease in my hypothermic patient, right? Because we're trying to conserve that heat as much as possible. Hyperthermia is a higher than normal body temperature, so we can't get rid of the excess heat. Lots of causes here. High temperatures, inability to dissipate heat, right? If we're not sweating appropriately, could be caused by exercise infection. Hyperthyroidism can also cause hyperthermia. And older adults are going to be more susceptible to heat exhaustion and heat stroke. They generally take longer to start sweating. And then they generally will also, just because of normal processes of aging, will produce less perspiration. Heat stroke is a medical emergency. They do require immediate intervention. And again, it's they're real concern for our active older adults, especially if they're living in those hot climates. So preventing hyperthermia, same thing. Keep the room temperature constant, 70 to 5. Make sure they have adequate fluids. They wear loose, light clothing. Perform chores or outdoor exercise at cooler times of the day. So they don't want to be outside in the heat of the day, which is usually like 10 to 2. Avoid direct sun exposure. Take cool baths or showers on hot days. Avoid alcohol. And if they are hyperthermic, you want to monitor their vital signs, call 911 if they have signs of heat stroke, and of course, move them to a cooler environment, give them fluids with electrolytes. Oops. All right. So Miss Johnson is an 86-year-old who lives alone in her apartment. While she was visiting her neighbor, she becomes dizzy and fell to the floor. She has a history of hypertension and takes a water pill for her blood pressure. Mrs. Johnson thinks she may have accidentally taken 2 pills this morning because she could not remember if she had already taken her medication. She was admitted to the hospital overnight for dehydration. So, what are the priorities for Mrs. Johnson? Oops. So, let's see. What is the goal? What do we want? What do we want to achieve for Miss Johnson here?
Safety.
You want to get her hydrated.
Hydration, safety, absolutely. Safety regarding what? What are some safety concerns with Miss Johnson?
Overdose for medication.
Okay, so medication's a big one, right? And she became dizzy, she fell to the floor.
And she could have a bad fall. I mean, that could
Yep,
lead
she
to
can have a
things.
bad fall and she can really hurt herself, right? So some of the things that could have led to her taking the wrong dose, did she forget? She can't read the label. Can she see the label? So oh, I'm like trying to see what else. What other things that she can do, letting her know what are some of the signs and symptoms of the lower blood pressure, letting, how much fluid does she need to drink, right? Because she is taking a diuretic, but what if she's on fluid restrictions, right? Doesn't say why she's on it. Does she have a pill box or a check sheet or a reminder set? And so, does she have someone that could come over maybe on Sunday afternoons or Sunday evenings, right? And help her set up her pill box for the week, so that she will be able to know if she took that medication or not. Um, she's also hard of hearing, and we talked about this too, right? So, what are some, be at eye level, right? Making sure, like I said, say, speak slow, low pitch, don't exaggerate. We always provide written information along with our clients, right? So that if, there's any risk of them not hearing us appropriately, that we can make sure that they still have the information that they need so that they can take it home and they can refer back to it later. All right. I know lots of information today. Any questions?
No.
All right. So you guys, don't forget, attend your live reviews, and our first exam will be next Monday at 3. If you need anything, feel free to reach out to me. You guys have my contact information. But I will see you guys next week. You guys have a great week.
Thank you.
Miss Jennifer,